Welcome back to Dental Notes and Mnemonics, and today we are going to discuss about the oral ulcerative and vesiculobullous lesions. First of all, before going into detail of the topic, we should have a basic idea of oral mucosa. Oral mucosa is a mucous membrane lining in the oral cavity. It serves as a protective barrier and it involved in sensation, secretion, and immune defenses. It is like a soft protective layer. It covers the underlying tissues and it is exposed constantly to food, saliva, microbes, trauma, and immune reactions. Imagine if something disrupts this balance, an infection, an immune attack, or physical injury, the mucosa reacts. And how does it react? By forming vesicles, bulla, or ulcers. Type of oral mucosa plays a major role in how bulli, vesicle, and ulcers form in the mouth. Several key factors determine this pattern. First is the keratinization. Area like gum and hard palate are keratinized, making them more resistant to trauma. So blisters and ulcers are less common there. In contrast, non-keratinized area like cheek, lips, soft palate, and floor of the mouth are more fragile and prone to damage, leading to vesicle or bulla formation. Second is the thickness of oral mucosa. Thinner mucosa can't withstand pressure well, so blisters form easily. Third is the vascularity. Areas rich in blood supply, like lips, show early signs of redness and swelling when they are injured. Fourth is mobility. That means the tissue that move more, such as inner ear, cheeks, or tongue, are more exposed to friction and accidental biting, which increases the risk of ulcers. Vesicles are small blisters having size less than 10 millimeter or 1 centimeter in diameter, containing clear fluid. Bulli are larger blisters greater than 1 centimeter in diameter. They are also filled with clear fluid. Ulcers are well defined, often depressed lesion with an epithelial defect covered by yellowish white fibrin membrane. An example is an Aphthous ulcer. All these lesions, they form a common pathway. It usually begins with triggers such as infection, autoimmune reaction, or trauma. This trigger leads to damage in epithelial cells or tissues of the oral mucosa. As a result, fluid collects beneath the damaged surface, forming a vesicle if it is small or bulla if it is larger. Over the time or due to friction, the roof of the blister may rupture, leaving behind a painful ulcer. So vesicles and bulli are often precursors to ulcers, depending on the extent and location of the tissue damage. Diagnosing these lesions may feel confusing at first because so of them look alike: red, painful, and irregular. But by asking just 4 clinical questions, you can narrow down the possibilities quickly and accurately. Let's walk through all these 4 diagnostic clues with example one by one. The clue 1 is the duration of the lesions. The first question is about the duration. How long have the lesions been present? If the ulcers or blisters appeared suddenly and have been there for less than 2 weeks, the likely cause is acute. For example, primary herpes simplex virus infection in a child, or hand, foot, or mouth disease from Coxsackie viruses. Another acute condition is erythema multiforme, which appears within days of a drug reaction or infection. If a lesion has been there longer than 2 weeks, it is considered chronic. This raises concern for conditions like pemphigus vulgaris, mucous membrane pemphigoid, or even oral squamous cell carcinoma, especially if the ulcer does not heal and it is painless. Next, ask, have you had these lesions before? If this is the first time the patient is experiencing painful oral ulcers along with fever, consider primary herpetic gingiva. But if the patient says these ulcers keep coming back, think of recurrent conditions like recurrent Aphthous or recurrent herpes labialis. And if the lesions come and go over several months in waxing and waning pattern, then you should think about episodic autoimmune diseases like pemphigus vulgaris, where the blisters may rupture and heal repeatedly. This question is especially helpful in distinguishing between isolated infections and the chronic immunological disorders. Third diagnostic clue is the number of the lesions. How many lesions are present, whether they are single or the multiple, plays an important role. A single lesion is usually associated with localized trauma such as cheek biting, denture, irritation, or thermal burns. However, when the solitary ulcer persists beyond 2 weeks, it raises concern for the chronic conditions like eosinophilic ulcers or tuberculous ulcer or even early squamous cell carcinoma. In contrast, the presence of multiple lesions often points towards a systemic etiology. In acute conditions like primary herpes simplex virus infection, there are multiple painful ulcers on keratinized mucosa. Hand, foot, and mouth disease shows multiple vesicles on the tongue, buccal mucosa, and extremities, again an acute viral pattern. Chronic autoimmune disorders such as pemphigus vulgaris or mucous membrane pemphigoid involve multiple recurrent chronic blisters and ulcers, often affecting both keratinized and non-keratinized mucosa. Stevens-Johnson syndrome is a severe mucocutaneous disorder, also shows multiple ulcerative lesions, usually in combination with skin and ocular involvement. So the number of the lesions gives an important clue. A single lesion suggests the local pathology, while multiple lesions points to systemic, infectious, or immune mediated conditions, whether acute or chronic in nature. Fourth diagnostic clue is the exact location of the lesion. The lesions appearing on keratinized mucosa such as gingiva and hard palate are often linked to viral infections like recurrent herpes simplex virus. Because these are tightly bound areas, provide a stable site for viral activity. In contrast, lesions on non-keratinized mucosa, including buccal mucosa, lips, and the floor of the mouth, are more typical of conditions like recurrent Aphthous ulcers, erythema multiforme, and pemphigus vulgaris, which often involves immune-related inflammation and the blistering of the oral mucosa. When the lesions are diffuse and affect both keratinized and non-keratinized mucosa, presenting with widespread blistering, bleeding, and peeling, or the desquamation, autoimmune diseases like pemphigus vulgaris or mucous membrane pemphigoid should be strongly considered. Oral lesions may be part of wider diseases affecting skin, genitals, or other organs. Asking about these symptoms help to identify systemic or autoimmune conditions like pemphigus, lichen planus, or any other infection, which is guiding the diagnosis and the treatment. Thanks for watching. I hope this guide helps you to confidently identify and diagnose oral ulcerative and vesiculobullous lesions. To like, share, and subscribe for more videos like this. See you in the next video. Till then, bye bye. Take care. Have a nice day.